Good morning, everybody. It's Lisa, and I am here live in the laboratory with Dr. Roberts, and I'm going to tell you a little bit about what we're doing today. If you've seen me speaking around lately, I know this comes out backwards on video, but you've seen me carry my heart in a box, and here is, oh, can I have more gloves? Thanks. Here is what we did July 27th, 2017. I came here, and we did a video, and this is my plastinized heart. And even the staff here who deals with human hearts all the time was absolutely fascinated by how real my heart looked plastinized. So we are now going to plastinize, well, we're going to work on the process of plastinization of 3 different donor hearts. And they're donated to the HCMA after transplant. 2 of the recipients of those transplants are watching us today. Sadly, one of them did not survive her transplant, and we will be doing her heart last. That is Irene. We're going to start today with Hannah's heart. So we're going to hopefully get Hannah to come in live here with us in just a second. And Hannah will be able to see her old arch nemesis in just a few moments. Okay, ladies and gentlemen, without further ado, we have a wonderful team here. We have Sam 1 and Sam 2, and Saba and Dr. Bill Roberts. And there is Dr. Roberts. And I'm going to let him kind of run the show here. This time we have a selfie stick. We're a little bit more organized. And we're going to get rid of your comments for now so I can see that Dr. Roberts has a really good view there. There we go. We're good. That's about where we need to be. Okay, so Dr. Roberts, why don't you tell us what you have in your hands or in front of you?
Well, this is Hannah's heart, and the left ventricle is very big. This coloring right here is different from that over here, and this is the portion that was right under her breastbone.
Oh, okay.
And that was stuck after the myotomy that she had earlier. So that's why it's discolored. But you can see if that's right under the breastbone, this left ventricle over here is quite big.
Wow.
And I can try to squeeze this heart, but I don't get any sensation of a cavity. I mean, it's all muscle. Mm-hmm. And that's one of the problems with hypertrophic cardiomyopathy. If you arrest, it's very hard
to get it back.
By squeezing to get blood out of the left ventricle. Should I go ahead and I feel the should we go ahead and
can I see where the ICD cap?
Yeah, you feel it right down there.
Oh yeah. And that's not going to come out, is it? It's going to stay in there.
Well, you can jerk it out, but
we'll leave.
The other thing to notice is look at the white tissue around that catheter.
Oh yes.
And that's the body covering it with its own human tissue.
Awesome.
Now this cut is...
that knife scared me last time.
Yeah, this is the sharpest knife in the world, really.
Let me get a blade.
Oh my goodness. Okay.
Switch. Helps when I have a blade.
Okay. Yeah, this is like a shaving blade, but it's very long. So in this cut, it's like a Hail Mary, because it's not predictable how it comes out.
I get so nervous when you did that to my heart, and I'm doing it for Hannah's too. Whoa.
Okay.
Wow.
Now this cut is directly anterior posterior. So right under here, right here is the sternum, the breastbone. So the first thing is the right ventricle. We call it right ventricle. It's really the anterior ventricle, one in the front. This is the ventricular septum. This is the aortic valve here. The anterior mitral leaflet, the mitral valve, and then the posterior wall of left ventricle. Now this heart has some scarring down here at the apex.
Yep.
And there is white thickening inside down here at the apex. Often this white thickening means that there was a thrombus there at one time. There's certainly not one now. But this is the outflow tract here. And this white plaque here, right here.
Is that from the
That's
systolic anterior
when
motion?
the anterior mitral leaflet was hitting it.
Got it.
So that's the anatomic equivalent of this systolic anterior motion. Aortic valve cuffs are fine. Now I'm sure this is bigger here.
Well, she had a myectomy in 2010.
Yeah. She still has a pretty thick ventricular septum here. This septum is up to about 1.9 cm, and the posterior wall is about 1.3. Normally, the septum and the posterior wall should be, it's usually of similar thickness.
Tip up a little?
Tip out the little.
There you go.
They can see it.
Okay.
He's not used to this camera stuff. That's okay.
But this is, I suspect that before the myectomy, and this is where they removed muscle, right here in the ventricular septum.
Mm-hmm. Oh yeah, you can see it's got a little odd shape there. It's a little squared off in the back.
Before that, I'm pretty sure the ventricular cavity here was of normal size. This is clearly dilated. One thing about myectomy is that there's no scarring in the ventricular septum as a consequence of the operation.
Somebody just asked me that earlier this week. What was going to happen to her heart post myectomy? Would there be scar? Now I have real proof from your mouth, and I didn't even ask you the question. I said there'd be no scar. There is none.
In contrast, the alcohol ablation leaves a scar.
Right.
So that's quite different. Now I'm going to cut into the right ventricle so you can see what it might look like. Okay. Now you can see the ICD catheter here.
Yep. You can. Can you get it to them straight off?
Can I move this a little
Yeah,
closer?
yeah. You can be the camera lady.
Oh, it's
Okay,
here.
there we go. Let's get a little bit closer.
Yeah, that's better.
That's better. There you go.
That's better. Closer, closer,
Closer.
closer. Okay. You're going to edit this.
No, it's
No,
live.
it's live.
Okay.
It's live right now.
We can edit it for YouTube later.
Okay. Now, I'm not sure why there's scarring here in the apex. The interval between the myectomy, and the heart transplant, Lisa, was what?
2000. It's in my phone. We wrote it down here. 2010. So it's 8 years.
Okay, so 8 years. So this probably was dilating during an 8-year period.
She got down to an ejection fraction of 20.
Well, this ventricle is very dilated, and
Those walls seem
the
very
ejection fraction is generally rather constant. As the ventricle dilates, the beating powers of the heart decrease. So the greater the dilatation of the left ventricle, the worse the ejection fraction.
Mm-hmm.
Now, I'll bet before the myotomy myectomy, her ejection fraction was 70% or something like that. There was no evidence of coronary disease here, is that
No.
before operation?
No.
Yeah, these coronaries look to be wide open. So that's one of the benefits of transplants. You get to know what your coronaries are like.
Without a cardiac cath. There you go.
Yeah.
Just a little probe. Mine were good too, you said.
Yeah. I mean, this probe goes in without a problem.
And if there was coronary disease, it would not go as easily.
That's correct.
Okay.
That's correct. So hypertrophic cardiomyopathy is one of these conditions where you can have scarring without coronary narrowing.
Right.
Now, coronary arteries, of course, are those arteries which supply the heart muscle with blood, and it's one of the conditions that causes scarring without coronary narrowing.
It's a really good picture of the papillary muscles there. It's really good
the
view.
papillary muscles are quite large in this condition. At the apices here,
It's scarred in like mine.
it's scarred.
Yeah.
It's scarred.
If you do a comparison, you can see my papillary muscles look a little bit different, but they're all scarred in there too, which I find interesting.
Well, the papillary muscles, it's interesting that they are supplied from coronary arteries that go down the side of the heart. Then they've got to penetrate the wall, and then they've got to go uphill. And that uphill route is about 3 times the thickness of here. So if any portion of the heart gets shortchanged in blood, it's the papillary muscles.
So we might want to start looking more at MRI data and looking at the papillary muscles. If there's any scarring within the papillaries, that might be an indication of progression of disease potentially.
Good thought. Good thought. Any other questions,
Yeah,
Lisa?
I think we've got Hannah's heart sectioned. Hi. That's Hannah's heart. And Hannah, I hope you're watching live. If not, you see it later. And Hannah's family. She's pretty amazing to have done as well as she did for as long as she did with that heart. And part of the reason we're doing this little project of, saving these hearts and seconding these hearts as we have is to show people that hypertrophic cardiomyopathy, we look on the outside, we look healthy, but we may not necessarily be doing so well inside of our hearts.
440.
Hannah, your heart weighed 440 grams. So it's kind of crazy when you think about how well you did for as long as you did with a heart that was not so happy. So now, Hannah, your heart is going to be shipped back up to Toledo, and Dr. Carlos Batista and his team are going to plasticize it. And now we're going to work on Amy's heart, correct? Okay, Amy, you're up. All
Now, the
right.
normal heart in a woman probably should weigh no more than 300 grams.
Wow, okay.
So 420, 440 is clearly bigger than normal, but it's not huge. Years and years ago, I saw a heart in a young lady with hypertrophic cardiomyopathy. She was 23, and her heart weighed 1,330 grams.
True
So,
HCM or Dannon's? What could be Dannon's? Yeah.
Hypertrophic cardiomyopathy is one condition that really increases the quantity of heart muscle. Okay.
Amy's post-myectomy, 2003-4. So she also had that scarring.
Amy was 45 when she had the heart transplant.
Yeah. By a couple of days, yes.
And her M&M was myotomy, myectomy was how many years earlier?
12,
Let's see, her.
2000.
No, Amy.
Amy.
Oh, this is Amy.
This
Okay.
is Amy.
So it.
Oh, I didn't put it up there. Amy was, I think it was 2003 or 2004.
Oh, so a long time ago.
Yeah. Yeah.
Okay. Now her heart actually is 355 grams. So this is, now we're missing some of the atrial wall.
Right, because you need those.
But it's not a huge heart. How much did Amy weigh?
I don't know exactly, but I would guess probably about 150, 160.
Okay.
She's
Okay.
tall. She's a tall girl. She's like 5'8", 5'9", if I had to guess.
Okay. So here we go again.
Here you go, Amy.
Again, this is a Hail Mary cut. You know how that Hail Mary?
Wow.
It came out of football, of course.
Of course. Wow.
And, Roger Staubach, when he threw in one of the playoff games, he threw this long 60-yard pass, and a reporter asked him after the game, after you threw that pass, what did you think? And he was a Catholic young man, and he said, I said a Hail Mary. So those long passes at the end of games now.
That's where they got the name.
Yeah. Okay, now this is a different heart.
Oh, yeah.
Now,
Wow.
If you look at the ventricular septum here, it measures up to
Turn it around.
2.3 cm. That's a very, very thick septum. Is that close
Yeah.
enough?
Yeah, all right. Everything come a little closer. There you go.
Okay. And her left ventricular free wall measures about 1.3 cm. So the septum is still thicker. Now, where is the thickest portion of the septum in hypertrophic cardiomyopathy? If you look at the aortic valve here and measure from the bottom of the right aortic valve cusp down to the apex, that's about here it's about just over, it's about 6.5 cm. Now, the thickest portion of the septum is usually not just under the aortic valve, but further down. So it's the thickest portion is usually midway between the aortic valve and the apex. Now here you can see that, and this is the anterior mitral leaflet, and you see how it pounds against the ventricular septum here. So it's white over here, it's white here. Now some of this whiteness I suspect was due to the surgical incision made at the myotomy, because the whiteness extends below the valve, way down here. So I like to see that, because a good myotomy, in my opinion, goes deep.
Right.
Deep in the septum, not just under the aortic valve. But here the anterior mitral leaflet is much thicker than the posterior leaflet, and that's due to its banging against the septum. There may be some scarring in this pap muscle down here also. These cuts, I try to get between the papillary muscles. Didn't quite get that out of the way. Amy, I hope you don't mind this.
It reminds me of roast beef. There we go. That's good enough.
Okay.
It is important to see that.
So this white stuff on this papillary muscle. Usually in hypertrophic cardiomyopathy, the papillary muscles are usually quite big. Now, this cavity, there's been some collapsing here. This cavity is probably, it's a little dilated, but not as much as Hannah's heart. The ventricular septum is still thick. And again, there's no scarring in the septum. Aortic valve is perfectly okay. Now, this is not an easy operation because you've got to protect those aortic valve cuffs when you stick a knife down here to take out this septum.
Mm-hmm.
And that's the danger of the operation, to protect that aortic valve. I don't see any any problem with the aortic valve here.
Is there scarring on the other side of the heart there?
I think there's a little scarring in the septum here.
Mm-hmm.
I bet it was present before the myotomy.
Oh, yeah. Yeah.
Well, let's look about the coronary artery, just because
Oh, I bet hers are clean. She's my little yoga girl.
they're clean as a whistle.
There you go, Amy.
So that's a good news, Amy. Okay. Okay. Usually in hypertrophic cardiomyopathy, the atria are big,
Mm-hmm.
dilated. The right coronary artery is great. Now, we don't have all the atria here because nearly half of the atria are still in Amy's
Mm-hmm.
body, because the heart transplant surgeons sew the atrial wall to atrial wall. So they don't.
So we still have a little HCMS somewhere.
Yes. Well, you have atrial HCM.
There you go. I'll take it.
Okay, the other comments or questions?
No, I think we have it figured out there. Amy needed a heart transplant because that's a thick, stiff heart.
Okay. Yeah, let's.
So we'll let them clean that one up. So I hope you are all learning a lot about hypertrophic cardiomyopathy. And I find it amazing the difference between those two hearts. They're women about 15, 20 years apart in age, and their hearts just look so different, but they had the same disease and went the same pathway, and they went to transplant. So we're going to have our third heart out, which to me is a very special heart because it belongs to Irene, who unfortunately did not survive her transplant. She died on the table because the donor heart would not start. Irene was a teacher, and she wanted to use her heart to teach others. So this is a very special moment that she really wanted. She wanted you to learn. She wanted to teach others about HCM. So Irene, and to her family, if they happen to be watching, we thank you for your contribution. Okay. Actually, I like this tipped up a little. Is that something I can
Okay.
lean
Now,
this way?
Amy's aorta is a bit.
Irene. That's Irene.
Irene, I'm sorry. Irene's aorta is a little thicker than normal. I'm not certain why. Now, she too had a myotomy in the past.
No, did she? I forget. I don't have her whole record in front of me. I'm so sorry.
Okay.
Let me get the record.
Now, this is a big ventricle.
She had a gradient of 77 back in 2009, and I believe she did go on for surgery. Yeah.
Okay, so all three of these
Oh, my mistake. I thought it was 2 and 1.
ladies have had a myotomy. So this heart is 375 grams. None of these hearts
Are huge.
are in the big categories. We've seen hearts with hypertrophic cardiomyopathy, 800 grams, 1,000 grams, 600, 500. Now, men have bigger hearts in general than women. Men are bigger than women in general. So that plays some role. It's hard to get, I can get only my index finger into the left ventricle, really.
Man.
Please.
Oh, wow.
So that muscle squeezing, still doing it.
It is very dense.
Yeah.
Very dense.
Yeah.
Okay. Wow.
Okay.
And what are these stitches here?
Oh, that's when they opened the aorta to do the myotomy.
And that's what's left behind.
That's what's left
Give them a
behind.
peek so they could see what's in there.
Okay.
See those little stitches in here.
Can you see that?
See that, guys? Okay.
Okay, here we go again.
That knife scares the Jesus out of me.
People ask me, well, how do you do that cut?
I asked you that. And you said, send me the heart. And now I understand why. Oh, wow.
Oh, wow.
Wow. How different can 3 hearts with the same disease actually look? Oh, wow. I mean.
So this one, see the anterior lateral papillary muscle sort of comes out of the apex.
Wow.
I'm going to cut this down so you can see the inside better. This is a blind cut, so that's why I'm never quite certain. Okay. That's the fascinating thing about this, or one of them, is that no 2 hearts look exactly alike.
You could leave it if you want.
Okay.
Because you just plasticize it and it could be movable.
Oh, we can?
Yeah.
Okay.
Yeah.
So they can pick it up, Dr. Roberts. And
Yeah. Actually, I think it's a really great
teaching tool.
teaching tool. Yeah. You can show.
Okay. This ventricular septum here.
I'm going to snip that little piece off.
Yeah. I think I'll do it this.
There you
go. Okay, now look at all this
Wow.
white endocardial thickening here. All that white. Now, no heart should have all that white on it.
Wow. That's tremendous.
So I think the surgeon did a good job here. Let me pull this back. I think that is a little artifactually.
Oh, wow. There you go. That does.
Okay. You can see how this anterior leaflet well, it's not very thick, the anterior leaflet. But the surgeon got deep from the aortic valve. He or she went all the way down. And I think that's a good operation. I think the major misconception is that the septum is thick only up here.
Right.
but it's thick all the way down. And if this is about halfway down from the aortic valve to the apex,
It's really thick there.
that's thickest portion. So if you don't go way down there,
You don't get it.
you don't get it. Very important concept.
And yet again, another endorsement for why high volume myectomies matter. You need somebody who's going to take it all the way.
Exactly. Now this left atrium is
Huge.
certainly relatively large, because we don't have all of it here.
Right.
And they must have opened, this is a suture line here. I'm not exactly sure.
I have to go get her
what's-
op notes and see if they did a
No,
base.
it's not. No, I was wrong. There are no sutures there.
Okay.
Okay, let's look at this right ventricle. Okay, well, the right ventricle is not very big. And the coronary arteries look perfectly okay. Yeah, okay, here we go. See how easy
Mm-hmm.
it is to get that probe in there. Okay, the left one is over here. And that's fine too. I remember a famous cardiologist in England, London, years ago, used to say that patients with hypertrophic cardiomyopathy don't get coronary disease. Well, that was obviously
Not 100% accurate.
I mean, the day I read that article, I saw a heart with hypertrophic cardiomyopathy that had terrible coronary disease.
Yeah.
So,
I don't think he was 100% right on that one.
It's interesting that all three of these hearts have classic features of hypertrophic cardiomyopathy, but the quantity of muscle is not great. I mean, they weighed 350, 375,
355,
355,
440.
and 440. I mean, they usually weigh more than that.
Now, do you see that the ones that you get obviously come to you from two pathways, autopsy or post-transplant? Do you see a difference in the post-transplant heart versus the sudden death heart in HCM?
I don't think so.
Okay. Same anatomy, same.
The first 30 years, they were all autopsies,
Right.
and many of those look. And
Morrow and McIntosh
It
and the
started
guys.
at NIH with Glenn Morrow, and it's a sad story, but Glenn Morrow had hypertrophic cardiomyopathy, and he did 299 of these myectomy operations.
Mm.
And early on, he would take out more muscle than he did later on. But there was a surgeon in Canada that didn't take out much, that did not take out much muscle, but he would split the muscle.
Oh.
And the results there were almost as good as when the muscle was taken out.
Mm.
Of course, the danger is you can split it too much and then
On the side.
produce a ventricular septal defect.
Mm. Easy.
Well, Lisa, you certainly are right that no two look the same.
Not at all. And I actually thought Irene was going to look more like mine because the reports actually looked more like mine at the end. But again, there's no. Oh, there we go. There's no comparison. They were So we have 4 hearts here with hypertrophic cardiomyopathy, mine being the plastinated one and then the 3 new ones. And they don't look identical. So, ladies and gentlemen, when I suggest that you call the HCMA and we go over your individualized anatomy, which how many times have you heard me say that? This is why. We don't all look alike. We aren't all the same. The disease process is very different, individual to individual. And your treatment and your management may change based on that anatomy. And thus, it's really important that you go to a high-volume center that understands the uniqueness of hypertrophic cardiomyopathy. It matters, and this visual display today, thanks to Dr. Roberts and his staff who are here with us today, can't thank them enough for this opportunity and for being able to share with you all the various anatomies that are hypertrophic cardiomyopathy. Any parting thoughts?
Lisa, thank you. This is not a disease, as Lisa indicates here, for an occasional surgeon to do this operation.
Right.
I'm afraid that too many surgeons think they can do this without any consequence. But this is a complex disease, and it should be done by those who have really studied the process.
While I have you here and on camera and an opportunity to interview the one who normally interviews people, tell me about where you think cardiac pathology is today and where your field needs to go, because I'm a little scared that there's not a lot of you left out there.
I don't tend to call it cardiac pathology. Cardiology now has all these subspecialties. You're expert in echocardiography. You're an expert in electrophysiology. You're an interventionist.
Right.
You're a preventive person. You know something about cholesterol. Well, I consider myself as a cardiologist whose focus is morphology. That is the structure of the heart. Now, if you say, well, Roberts is a pathologist, the implication out there is that, well, he's sitting down looking at slides all day long, looking at breast biopsies and other things. Mm-hmm. Well, I go to all the clinical conferences and focus on heart, aorta. I used to do a lot of lung work, but not so much anymore. But my office is next to the cardiologist. The problem is in cardiac morphology is that there's no money in it for the pathologist. Cardiac work does not bring money to pathology department. So I'm paid by the foundation.
Right.
I was at NIH for 32 years. I was paid by taxpayers. When I started, there were quite a number of people who focused on cardiovascular pathology, morphology. That's gone.
What do you think we lose when we lose that? The understanding of this kind of anatomy?
Well, heart disease is a specialized arena. And I think that many pathologists think, well, that's easy stuff, you just have a blockage in a coronary artery. Cardiac morphology, pathology, is a gross examination. Histology rarely pays dividends.
Okay.
It's studying that heart grossly. I used to cut these hearts up in the surgical pathology laboratory, but Saba set it up. We can do it here. I would see a staff man come into the surgical pathology suite once in a month. These hearts around the country autopsies are done by the youngest person, the first-year resident. Grossing, cutting the tissues that come into surgical pathology to make the slides, they're done by first-year residents, second-year residents.
Mm-hmm.
Now, what does someone just out of medical school know about hypertrophic cardiomyopathy?
Sadly, not much.
I mean, that's the scenario we're in.
Mm.
So I want to live a few years longer.
Well, we want that too. We
I'm
want
trying.
that too. Well, you've seen what happens when things don't go well with the heart, so I'm sure you've led a pretty healthy life. You yelled at me to put my, push the table back.
Well, it's very important for everybody to keep their cholesterol levels down, keep their blood pressure levels down. It's interesting that we talked about earlier that I used to say the frequency of hypertrophic cardiomyopathy was 1 in 500. That's what Barry Maron told. And you say now it's gone down to 1 in 200.
1 250. There's some controversy still, but
Now, it's
common.
interesting that familial hypercholesterolemia, the cholesterol gene, is present in originally Brown and Goldstein taught it was 1 in 500, but now we know it's about 1 in 200.
common.
So hypertrophic cardiomyopathy has about the same frequency as genetic hypercholesterolemia.
Well,
I mean, that's a common situation.
as is HCM. We're a common thing.
Yeah.
Okay, well, I've taken so much of your time today.
Lisa, thank you.
Thank you
You're
for having
great.
us here. Thanks to the entire staff for organizing this and helping, and Becky back in the office who helped with all the paperwork. Just profoundly grateful and thankful that we have this opportunity to see these hearts in this way, save these hearts, and teach with these hearts so more people understand hypertrophic cardiomyopathy. And I promise to shout out to Christina Basso over in Italy. This is her thing. She loves cardiac pathology, so hi, Christina. And to Amy for letting us have this heart to teach with, and to Hannah and to Irene. Thank you all so much for giving so much of yourselves, literally, so that we can help teach others. Thank you all and have a great day.